Today, we're jumping right into a true medical mystery. We're talking about a devastating neurological emergency, herpes simplex encephalitis. It's a condition where a super common virus can become an absolute catastrophe for the brain. So let's start right where it all begins, the moment a patient walks into the emergency room. Okay, so picture this. This is the classic high-stakes scenario. A patient's brain is clearly under attack, and you can practically hear the clock ticking. They're declining fast. So what in the world could be causing this? This is exactly where our investigation kicks off. All right, the symptoms we're seeing, they're screaming encephalitis. Now, it's really important to get this straight. This isn't meningitis. Meningitis is inflammation of the lining around the brain. Encephalitis is inflammation of the brain tissue itself. And that explains why the symptoms are so severe. It's not just a bad headache, it's a deep change in who the person is, and it doesn't just go away. This is the broad category for our medical whodunit. So what's the one culprit we are most afraid of in this situation? Herpes simplex encephalitis, or HSE. And why? Because of this number right here, 70%. That is the mortality rate if this thing is left untreated. The stakes, they honestly could not be higher. Okay, so how do we prove our suspicion? Well, that brings us right to section 1, cracking the case. Think of this as pure medical detective work. It's a frantic race against time to pull clues from the patient's brain and their spinal fluid. Our investigation is going to follow 3 critical paths, all happening at the same time. We're going to get a sample of the cerebral spinal fluid with a lumbar puncture, we're going to take a picture of the brain with an MRI, and we're going to listen in on its electrical chatter with an EEG. Each one of these gives us a totally unique piece of the puzzle. And boom, our first results are in from the lumbar puncture, and they are already telling us a story. We're seeing a slight bump in the white blood cell count, but here's the key. They're mostly lymphocytes, which are the body's main virus-fighting soldiers. The protein is up, a clear sign of inflammation, and we might even see some red blood cells, which tells us the virus is causing some bleeding. And maybe, most critically, the glucose is normal. See, bacteria love to eat glucose, so a low level would point us away from a virus. This whole pattern is pointing its finger directly at a viral intruder. But the real slam dunk evidence from the spinal fluid comes from the PCR test. It actually finds the virus's DNA. It's our gold standard. But, and listen up, because this is so important, there's a catch. In the first 72 hours of the illness, the test can actually be falsely negative. So the takeaway is, if your gut is screaming HSE, but that first PCR comes back negative, you have to repeat the test in a few days. So while we're waiting for that PCR result to cook, the MRI comes back. And wow, this is basically the smoking gun. You see that bright white area lighting up in the brain's left temporal lobe? That's called hyperintensity, and it means there's a ton of swelling and inflammation. For some reason, the herpes simplex virus just loves the temporal lobes, which makes this finding a massive red flag for HSE. And finally, the EEG. This is where we get to kind of listen to the brain's electrical activity. In HSE, we often find this very specific pattern called PLEDS. The best way to think about it is like a broken smoke alarm in the brain. Just this repeating, rhythmic electrical spike firing over and over again from one spot. It's the signature of an electrical storm happening in the exact same spot that the MRI showed us was on fire. Okay, we've got our diagnosis, but how on earth did this happen? Let's switch gears and move to section 2 to really understand our enemy, the virus itself. How does a virus that so many of us carry around cause this kind of catastrophic brain damage? Now, there are 2 main culprits in the herpes simplex family. You've got HSV1, the one we usually associate with cold sores. That's the usual suspect here, causing over 90% of cases in adults. Then there's HSV2, which is much, much rarer in adults, but is actually the more common cause you'll see in newborns. So how does this tiny saboteur sneak past all the brain's defenses? Well, for millions of us, HSV1 isn't really doing anything. It's just hiding out, totally dormant, in a bundle of nerves near the brainstem called the trigeminal ganglion. But then, something triggers it to wake up, and instead of traveling down the nerve to cause a simple cold sore, it takes a wrong turn. It travels backwards, we call it retrograde, straight up the nerve axon and marches right into the brain. And once it's inside, it is just pure chaos. The virus literally hijacks our brain cells, our neurons, and forces them to make millions of copies of itself until they swell up and just burst. This creates what's called hemorrhagic necrosis. That's bleeding and the death of brain tissue. Then the body's own immune system rushes in to fight the infection, but that causes even more swelling and, sadly, even more damage. That whole destructive process, that is exactly what's causing the terrifying symptoms we see. So let's move on to section 3 and talk about how we fight back. This is the most urgent part of the story, where literally every single minute counts. And this brings me to what is maybe the single most important rule in all of this. It's simple. Treat before you know. You absolutely do not wait for that gold standard PCR test to come back. You treat the second you suspect it. Why? Because that virus is burning down brain cells with every single hour that passes. You treat before you know for sure. Period. So what's our weapon of choice? It's an intravenous antiviral called acyclovir. How it works is pretty cool. It basically jams the virus's copy machine, so it can't make new copies of its DNA. We give it at a really high dose for a long time, usually 2 to 3 weeks, to make absolutely sure we stamp out the infection in the brain. And if you need to know why we're so aggressive about this, well, here it is. Study after study has shown that waiting more than 48 hours to start acyclovir leads directly to worse outcomes and a much higher chance of death. That rule, treat before you know, it's not just a guideline, it's what saves lives and preserves brain function. All right, so let's say our patient gets the treatment right on time. The virus is being fought, but what happens next? What does the future hold? Let's move to our final section. The aftermath. What is life really like after surviving something this severe? And while this is where the story gets really sobering, even with fast, aggressive treatments, the outcome is far from a sure thing. Now, acyclovir drops the mortality rate from that terrifying 70% down to between 10 and 25%. But look at the rest. The vast majority of people who survive are left with some level of disability. A full recovery is, unfortunately, pretty rare. And if you think back to that MRI, these disabilities make perfect sense, right? The temporal lobes were hit hard, and they're ground zero for memory and language. So it's no surprise that survivors often have really severe amnesia or aphasia. Many also develop a brand new seizure disorder or go through profound changes in their personality and behavior. And then, in what is just a truly cruel twist, sometimes the fight isn't over even after the virus is gone. For some patients, the initial viral infection actually triggers a second attack. This time, the body's own immune system, the one that was supposed to be the good guy, gets confused and starts attacking healthy brain cells. It causes a full-blown relapse weeks or even months later. It's a second wave of attack, this time from the inside. Which really brings us to the big final question, doesn't it? The outcome of HSC depends almost entirely on how fast we treat it. But the early symptoms, fever, headache, a little confusion, they can be so vague, so easy to brush off. The real challenge, then, isn't just medical, it's systemic. How do we, as a healthcare system, get better at spotting this killer in its earliest stages when we have the best shot to really change the outcome? It's a question we all need to be thinking about.